Thank you for this opportunity, IPCI team. Okay, so the topic given to me is to assess the side branch after utility of FR in bifurcations. So I would classify the utility of bifurcation to plan the PCI that is before PCI, so that we can identify the revascularization strategy, to assess the side branch or even the main branch, and post PCI. I'm going to confine myself to before PCI and peri PCI. Post PCI itself is a big topic even for bifurcations. To know what exactly bifurcation lesion means, let's restrict ourselves to largely accepted randomized studies published in very good impact factor journals, starting from DIFFER to FAME3. This is the definition they have utilized. So when I am talking about bifurcation lesion, I am talking about these definitions. Why FFR is essential? We know we have a tendency to overestimate lesion severity, which we call it as visual functional mismatch. The visual functional mismatch is higher in proximal lesion compared with distal lesion. That is, a 50% lesion in distal LAD may not be significant as compared with the 50% lesion in the proximal LAD, because obviously of the myocardial mass supplied by it. If you look at this particular chart, the dots are throughout that scatter plot. That means diameter stenosis doesn't correlate with physiology. Some of them has got significance if they are going to be more than 50%, especially if they are going to be located in the proximal lesions. What is the importance of a FFR in a jail circumflex, that is left main to LAD? If you look here, out of 43 patients, only 5, you can count, only 4 are significant. That is, with a lesion of 5 more than 50%, FFR less than 0.8. In another study, something around 5 or 6 patients had, out of 29 patients, had a FFR of less than 0.8, and most of them had a lesion more than 50%. So the visual functional mismatch holds true even after stenting. Coming to the evidence, it all starts with Hu et al., who published the study way back in 2008 in European Heart Journal, where it's not a randomized study, where they consecutively studied the patient into two-arm angiographic guided PCI and FFR guided PCI for the side branch assessment. They enrolled the side branch, they defined the side branch as below. They found that there is a significantly reduced side branch intervention if you do FFR. However, the primary outcome of the study was clinical outcome at 9 months, which was not significant. It's it was so low the number of events, we cannot get any conclusion from this particular data. However, they did one important assessment. They also did a follow-up FFR after 6 months in those patients who had an initial post-procedure FFR. And they found that the FFR which was left at index procedure remained the same even at 6 months. That's an important point to remember. So FFR did not worsen in such patients in whom a side branch FFR was done and was found to be not significant, or side branch FFR was done and was found to be significant, and they did a POBA alone for the side branch opening followed by FKBI. And that is one important point, that is a very reassuring point for our clinical practice. Following which, Chen et al. From China did their DK-6 study, where they randomized 300 plus or 340 plus odd patients into two arms, angiographic guided PCA and FFR guided PCA. One arm goes for angiographic PCA. The angiographic PCA, they went for a second FKBA followed by requirement of second stenting if at all there is going to be luminal narrowing of more than 30%, or TIMI3 flow less than 3, or dissection. And they intervened in the FFR arm if FFR is less than 0.8. They found that the 1-year clinical outcome was not significant between both arms. This is the primary outcome of the study. The rest of the findings, whatever I'm going to tell, is only hypothesis generating. That is, they are not powered, so only hypothesis generating. In the hypothesis generating point, they found that there's no difference between side branch interventions. However, the number of stents put in the side branch was significantly higher if you are going to take a angiographic guided therapy. Further, they reclassified the restenosis that happened in such patients. They found that as compared with the two-stent strategy based on angiogram, the other 3 strategies, that is provisional based on angiogram, FFR guided two-stent strategy, and FFR guided provisional strategy, the diameter stenosis is more than 70%. That is the late lumen loss at 1 year was significantly higher in the angiography guided two-stent strategy. The point, this very, very important point. Basically, we are converting a provisional stent strategy into a two-stent strategy based on some side branch issues. So if we identify those lesions, there are true bifurcation lesions. At that point of time, definition strategy was not available. So these are all very complex bifurcation lesions. Maybe upfront they should have gone for a two-stent strategy, which was not the question put forth in front of them. So this is an important point to be remembered. Again, a hypothesis generating. However, the primary outcome, there was no difference between these two strategies at the end of 1 year. The Achilles heel for FFR is crossing. So there was a paper published in 2016 where they did a meta-analysis. They found that there's no difference between a routine workhorse wire crossability and FFR. The cross failure was something around 3 to 4%. However, DK cuts, the failure rate was 10%, something around 9.4 to 10%. So the 1 in 10 patients, we may not be able to cross. Keep it in mind. How safe are we in left main if we leave a FFR negative patients? This is again data from South Korea, where they followed such patients after left main LAD circumflex crossover, and they classified the patient into low FFR, high FFR. They found that patients who had a residual FFR of more than 0.8, of course, they did well significantly as compared to those patients who had an FFR of less than 0.8. Important point to remember is having an FFR of less than 0.8 significantly affected their survival also at the end of 5 years. They causes more death, more MI, more MACE, more target lesion failure. So FFR less than 0.8 in a single stent strategy in left main, try to intervene that lesion. Don't leave the patient with the FFR less than 0.8 even without a plug. That's a carinal shift, so it's causing significant hemodynamics. How these strategies helped me in my clinical practice before revascularization? Here's a 52-year-old male done way back in 2013. Triple ACS, culprit is RCA, long lesion. That's a bifurcation lesion in the circumflex. This is a borderline LAD lesion. I thought it was not going to be significant. However, it turned out to be 0.78. Freedom got published at that point of time. So he's a diabetic, normal LV function, triple vessel disease. I sent the patient for cabbage. That's no question about it. And Freedom conveys one important point. There's no role of syntax when we are handling a diabetic triple vessel disease. Absolutely no role. It is cabbage. Number two, I was thanking myself that this patient, I sent the patient for cabbage because a month later he got readmitted with a necrotizing gangrenous cholecystitis for which he has to go for an emergency laparotomy, not laparoscopy, laparotomy and cholecystectomy. If at all I would have intervened with multiple stents in this patient, I have to scratch my head, like thanks to FFR. So this is another patient where angiography was done outside. So this is the patient who had an ACS, good LV function, was diagnosed to have a borderline LAD and significant diagonal, advised PCI to diagonal. We reviewed the angiography. We went and did FFR to this particular patient. We didn't even give adenosine. The PDPA itself was 0.73. So we aborted giving adenosine. We proceeded with a bifurcation strategy PC. It was a complex bifurcation definition strategy. We did a mini crush. He was doing fine 5 years after the procedure. Last COVID pandemic, second COVID pandemic, we lost the patient because of COVID. So peri-PCI, what is the role of FFR in side adjustment? This is the algorithm what I follow in my practice. The left side, if I do an FFR to a side branch before intervention, on the right side, if I do FFR after putting a stent. Patient 1, 67-year-old diabetic, recent onset class angina, persisting pain, positive for ischemia at 7 minutes. So this is a mid-LAD lesion after the diagonal, a focal kind of lesion. FFR was done to LAD 0.69 via diagonal. The only strategy that has been shown in a randomized study to prevent side branch closure is placing a wire inside it. That's the only thing that has shown to prevent acute vessel closure side branch. So as far as possible, try to keep a wire. So this is the stent being placed. After ballooning, we placed a stent, and this is the post stent after angiogram after stent. We used the 3.0 balloon to post dilate it and 3.25 to pot it. I have decreased the number of pictures so as to save time. So this is the angiography after post dilatation. Significant pinch in the diagonal was noticed. FFR wire was placed. FFR was 0.74. We kissed it at 2.015. and same 3O into 10 balloon. This is the post kissing. I realized some geographical miss in the proximal zone. Now I took the help of IVUS. I didn't use it before that. The stent got landed in in the site where significant plaque burden was there. So I used identify the second zone, something around 8 millimeter proximal to the last zone, and put a second stent and finish the procedure. So this helps to sort out the problem what we created. So this patient belonged to this pathway, pre-FFR not done, continue with provisional strategy. When you go for intervention, clinical, that is chest pain, ECG, significant ST elevation depressions, angiographic TIMI less than TIMI 3 flow or flow limiting dissection, or FFR less than 0.8. This patient had the same in diagonal, we did FKBA, issues resolved, we finished the PCA, we came out. Another patient, 73-year-old male, class 2 angina, strongly positive treadmill, normally function. A kind of, I would say 0-1-0 lesion in the osteal LAD. There is no question of nailing this particular lesion. Lesion starts at the narrow angle, lesion starts at the distal left main itself. So we imaged it with the IVUS. For want of time, I didn't show it. There was only a fibrotic block. We cut it with the Wolverine, post-Wolverine angiography, and we took a 3038 platinum chromium based Everol muscle stent, deployed it, bought with a 4O balloon, and there appears to be a kind of 50% pitching in the circ. We did FFR, it was negative, and we left the patient like that. He's doing fine. It's almost 9 months or so. So this category of patient, again, I didn't do pre-FFR to circumflex because there was not much disease there. Continue with provisional strategy. We did FFR. FFR was negative. We finished the PCI. That's it. Third patient, 47-year-old male, old anteroceptal MI, now class 3 angina, bonded dysfunction, had a PAD, stator post aorta biiliac bypass. This is the angiography of the particular patient, kind of a very big diagonal. He had a critical RCA lesion which was stented before intervening the LAD by a diagonal bifurcation. So we ballooned it and put up stent and inflated the stent. This is the post-stent angiogram. There's a significant pinching in the good sized diagonal notor with the kind of less than TIMI 3 flow, maybe a TIMI 2. The flow is slow in the major diagonal. Wired, then we ballooned it with a 2.5 into 10 balloon. There was some amount of haziness. We thought of leaving it. However, we then proceeded with doing a FFR. It was 0.44. It's a huge, kind of a equally good sized diagonal. 0.44. Then we proceeded with a culotte technique in this particular patient. I didn't go through the steps of the culotte here. That was not the intention of this particular presentation. So after POBA, redo an FFR. We did an FFR again, not again. We did the first FFR in this particular patient and found that it's still persistently significant. Then we proceeded with culotte. So in this particular patient, we went with the provisional stenting strategy. There was some slow flow angiographically. We ballooned it. Kissing balloon was done. Issue didn't resolve because FFR was persistently positive. Then we culotted the patient. So the strategy is very simple. DKK showed no evidence of benefits, no evidence of increased benefits of FFR guided strategy. Clinically, hemodynamically, ECG wise, angiography wise, whatever data we are getting is enough to take whether you need to intervene a side branch or not. With this, I would like to conclude.